Good morning, esteemed colleagues. Today, we're diving into a topic that's both common and potentially perilous: dangerous low back pain. This isn't just about identifying a pinched nerve, it's about recognizing when a seemingly simple backache might be masking a much more serious underlying condition. Think of this as your red flag guide for the chiropractic clinic, helping you navigate the treacherous waters of potential emergencies, triage, and red flags. Our first order of business is triage. We need to quickly assess whether a patient belongs in our office or if they require immediate referral to another medical professional. It's about being vigilant, asking the right questions, and understanding when to call for help. The next slide presents our critical red flags. These are the warning signs that should raise a red flag and prompt further investigation. Imagine these as the flashing red lights on a dashboard. They demand immediate attention. The key here is mechanically reproducible pain. If a patient's pain cannot be made worse or better with movement, or if they cannot find a position of relief, that's a big red flag. It could signify inflammation, infection, or even something more serious. We also need to be on high alert for patients presenting with fever, nausea, or vomiting alongside their back pain. Now, before you all start panicking about every patient with a stiff back, let's take a breath. Not all red flags mean doom and gloom. It's about knowing how to react, not overreacting. Remember, your history and examination skills are paramount. We need to be meticulous, asking questions that delve deeper into their symptoms and medical history. Imaging, when appropriate, can also help us gain a clearer picture. But above all, the most crucial tool we have is the ability to triage effectively. Do we send them to the ER, urgent care, a specialist? Or can we manage their care in our primary care setting? The answer lies in carefully evaluating the severity of their symptoms and the presence of those ominous red flags. Scenario examples. Let's look at some real-world examples. Imagine a patient complaining of severe low back pain accompanied by nausea and vomiting. It could be a simple case of bad sushi, but it could also be a ruptured disc, a potentially serious condition. Now, picture a patient with fever and malaise on top of their back pain. While it could be the flu, it could also be a more sinister infection. And what about that patient with severe right-sided back pain and fever? This could be a sign of a retrocecal appendix gone bad, requiring immediate surgical intervention. Finally, consider a patient with vague low back pain and abdominal discomfort. This could be a case of tubal pregnancy, a serious medical condition that requires prompt attention. Remember, these are just a few examples. We see all sorts of unexpected presentations in our practice. It's our responsibility to remain vigilant and treat each patient as a unique case. Retrocecal appendicitis. Now, let's take a closer look at one of those potentially dangerous conditions, retrocecal appendicitis. This sneaky little culprit can present with back and flank pain, often mimicking mechanical low back pain. However, there's a key difference: the psoas sign. Imagine a patient lying on their back with their right leg extended. As you try to flex their right hip, they experience excruciating pain. That's the psoas sign, a hallmark of retrocecal appendicitis. They may also exhibit the hamburger sign, where the pain is localized to the right lower quadrant of the abdomen. Mechanical low back pain won't produce this localized pain, so it's a critical clue to look for. Abdominal aortic aneurysm, AAA. Now, let's move on to a potentially life-threatening condition that often presents with nonspecific back pain, the abdominal aortic aneurysm, AAA. Imagine this: a ticking time bomb hidden within the abdomen, waiting to rupture. Aneurysms are defined as a dilation of the aorta, typically exceeding 3 centimeters. Our patients might present with nagging, chronic, low back pain, especially if they have a history of hypertension, are over 55, or have a history of heart attack or popliteal aneurysm. We need to be vigilant with our examinations. Listen for a vascular bruit using auscultation. Feel for a diffuse pulsating mass in the periumbilical region, and examine lateral radiographs for erosion of the anterior vertebral bodies and calcification of the abdominal aorta. Signs of AAA. What are some key signs to look for? The most common presentation is back pain without abdominal pain, accompanied by hypotension. Look for a pulsatile mass, as this is a telltale sign. Patients within AAA often appear pale and sweaty, with a rapid and weak pulse. This can mimic a heart attack, making early recognition and intervention crucial. Prevalence of AAA. Let's put this into perspective. In autopsy studies, the frequency of AAA ranges from 0.5 to 3.2%. The prevalence rate is about 1.4%. Now, consider the city of Chicago, with a population of 2.71 million. That translates to roughly 110 aortic ruptures occurring in Chicago each year. That's a sobering statistic. It emphasizes the importance of early detection and intervention. Symptoms of AAA rupture. A ruptured AAA is a medical emergency. Patients will present with excruciating abdominal or back pain, often accompanied by a pulsatile abdominal mass. Other symptoms can include groin pain, syncope, paralysis, or a flank mass. It's important to remember that the symptoms can mimic other conditions, such as renal calculus, diverticulitis, hernia, or lumbar spine disease. This is where our clinical judgment and thorough examination skills are critical. Osteomyelitis. Now, let's shift our focus to vertebral osteomyelitis, a serious infection of the vertebrae that can be easily missed. This condition often afflicts individuals with diabetes, drug addiction, alcoholism, or a history of corticosteroid use or recent urethral instrumentation. The key here is the insidious nature of the pain. It often develops gradually over 1 to 3 months, making it easy to dismiss as just another case of back pain. What's even more concerning is that patients may not exhibit systemic symptoms initially. By the time patients present to us, they often have a history of relentless back pain, tenderness, spasm, and loss of motion. This is where early detection becomes critical. We need to be vigilant, recognizing the subtle signs and symptoms and understanding the typical progression of the disease. Delay in diagnosis can lead to significant complications. Laboratory testing for osteomyelitis. Laboratory testing plays a vital role in diagnosing and monitoring osteomyelitis. The ESR and CRP levels are elevated in the majority of cases, often the only abnormal laboratory value. Imagine a patient presenting with back pain and elevated CRP/ESR. It should be a red flag, signaling the need for further investigation. Imaging for osteomyelitis. Now, let's talk about imaging. Radiography can be helpful, but it's often not enough, especially in the early stages. Soft tissue edema may be visible after a few days, but bony changes may not be apparent for weeks. Remember, ERs, chiropractors, and walk-in clinics often don't have the expertise to interpret these subtle findings. This is where the expertise of a radiologist is crucial. The MRI is the gold standard for detecting vertebral osteomyelitis. It provides a detailed view of the spinal structures, revealing early signs of infection that may be missed on radiographs. However, here's the challenge: securing an MRI for nonspecific, non-traumatic low back pain without systemic symptoms can be difficult. Insurance companies often require a strong justification, which can be frustrating. Treatment for osteomyelitis. Treatment for vertebral osteomyelitis involves surgical debridement to remove the infected tissue, stabilization with instrumentation or fusion, and long-term intravenous antibiotics, typically for 6 to 12 weeks. Osteoporotic fracture. Now, let's shift our attention to osteoporotic fractures, a condition that can have a devastating impact on a patient's life. Imagine a patient presenting with acute pain superimposed over chronic discomfort. They might have no history of trauma, or they may recall a snap after lifting a small object or simply bending over. This is often seen in postmenopausal women, particularly those who are petite, white, and have a family history of osteoporosis. The chronic pain associated with osteoporosis is often caused by microfractures of the trabeculae, the tiny beams of bone that give the vertebrae their strength. Think of it as a gradual collapse of the bony structure, leading to pain and instability. We need to be aware of the different types of osteoporotic fractures. Look at the X-ray, describe the image vividly. The normal vertebra is strong and stable, but in osteoporotic fractures, the vertebral body can collapse, leading to a wedge-shaped or biconcave deformation. Causes of osteoporosis. Osteoporosis is often linked to lifestyle factors. Poor diet, smoking, excessive alcohol consumption, and excessive soda intake can all contribute to weakened bones. Corticosteroid therapy can also significantly increase the risk of osteoporosis. Treatment for osteoporosis. By the time we see patients with osteoporotic fractures, conservative care is often focused on pain control. Anecdotal reports suggest that gluten and lectin avoidance diets may help with remineralization, but more research is needed. It's crucial to understand that the time to treat osteoporosis is early in life, with a healthy diet and weight-bearing exercise. Differential diagnoses. When a patient presents with a non-traumatic spinal fracture, we need to consider other possibilities, such as metastasis or multiple myeloma. Metastatic disease is more common, so we need to rule it out first. However, multiple myeloma, while less frequent, should also be on our radar, particularly in male patients between 55 and 65 years old. Treatment considerations for osteoporotic fractures. With osteoporotic fractures, we need to be mindful of the delicate nature of the spine. High-velocity techniques should be avoided, and manual therapy approaches should be carefully considered. We also need to be proactive in addressing the patient's overall health, including balance training, strengthening exercises, and home safety measures to prevent further falls. Multiple myeloma. Now, let's talk about multiple myeloma, a serious bone marrow cancer that can present with nonspecific back pain. It's often characterized by diffuse osteopenia, which is a thinning of the bones. This can be seen as early as the age of 55, making it a significant concern for our patients. Later, we might see punched-out lesions on imaging, which are small, round areas of bone destruction. The clincher for diagnosing multiple myeloma is the presence of Bensett-Jones proteinuria in the urine. This protein is produced by the abnormal plasma cells that characterize this disease. Remember, multiple myeloma is relatively uncommon. But, when we see a male patient in their 50s presenting with osteopenia, it should raise a red flag. Men typically don't develop osteoporotic changes until their 70s. Prevalence of multiple myeloma. Multiple myeloma affects approximately 5 to 6 people per 100,000 every year. In 2005, an estimated 15,980 new cases were diagnosed, and over 50,000 individuals in the United States were living with the disease. Understanding multiple myeloma. Multiple myeloma is characterized by an overproduction of abnormal plasma cells in the bone marrow. These cells produce excess amounts of monoclonal immunoglobulin, which can be detected as an M spike on protein electrophoresis. This excess immunoglobulin can cause a range of problems, including hypercalcemia, anemia, renal damage, increased susceptibility to infections, and impaired production of normal immunoglobulins. Metastasis. Now, let's discuss metastasis, the spread of cancer from a primary site to other parts of the body. Metastasis can affect the spine, causing significant pain and instability. Patients with metastatic spinal disease often present with unrelenting, intense, and progressive pain. They may appear anxious, fatigued, and desperate for relief. The pain is often worse at night and doesn't improve with positioning changes. While night pain is a common symptom of cancer, it's not specific to the disease. There are other factors that suggest a higher likelihood of cancer, such as advanced age and a previous diagnosis of cancer. Common primary sites of metastasis. The most common primary sites for metastatic disease are breast, prostate, lung, colon, and stomach. In men, prostate cancer is the most frequent primary site. It's important to note that metastases from carcinomas are the most common malignant tumors involving the skeleton. Common sites of metastasis. Metastatic tumors often affect the vertebrae, pelvis, proximal femur, ribs, proximal humerus, and skull. More than 90% of skeletal metastases are found in these areas. Imaging for metastasis. Technetium 99m bone scanning, or radionuclide bone scanning, is a cost-effective and readily available method for screening for bone metastases. However, PET scans have surpassed bone scans in recent years. MRIs are sometimes used, but insurance companies often require strong justification for this modality. Describe the images vividly: prostate, breast cancer, vertebral metastases, and a normal PET scan. These images illustrate how imaging can be crucial for diagnosing and monitoring metastatic disease. Kidney stones. Finally, we come to kidney stones, a common and often excruciating condition. Kidney stones are solid masses of crystals that form in the urine and build up in the kidneys. Kidney stones are primarily composed of calcium oxalate, 85% of cases, uric acid, often mixed with calcium oxalate, or cysteine. Calcium oxalate stones are radiopaque, while uric acid stones can be either radiolucent or radiopaque, depending on the composition. The most serious complication of a kidney stone is complete renal failure. While stones often pass without medical intervention, larger stones exceeding 5 mm in diameter may require medical management. Symptoms of kidney stones. Kidney stone pain is intense and characteristic. It typically occurs suddenly and wakes the patient at night. The pain is localized to the flank and may be associated with nausea and vomiting. Patients often move constantly to find relief. The pain from a kidney stone can radiate to other areas. As the stone moves through the ureter, the pain may radiate to the ipsilateral testis or labium. If the stone becomes lodged at the ureterovesical junction, patients may experience urinary urgency and frequency. Kidney stone pain is often described as the worst pain ever experienced, even worse than childbirth or a gunshot wound. The pain is not caused by the stone tearing tissue, but rather by the stretching of the tissues as they are blocked by the stone. Patients who experience repeated kidney stones should undergo a thorough workup to identify the underlying cause. There could be serious underlying conditions such as metastatic cancer or parathyroid tumors. Visceral referred pain. Now, let's discuss visceral referred pain, which is pain originating from the internal organs. It can be caused by a variety of factors, including ischemia, acidity, muscle spasm, or distension of hollow organs. Visceral pain is often referred to the surface of the body. For example, cardiac pain can be referred to the neck and jaw, gallbladder pain to the right shoulder, and kidney or bladder pain to the groin or hip. This slide presents a case study of a patient who presented with low back pain, gluteal pain, thigh pain, lateral and anterior shin pain, dorsal foot pain, and unusual sensations. Their pain was exacerbated by extension and relieved by end-range extension. The patient's history, examination findings, and response to treatment suggested a diagnosis of visceral referred pain from fibroids. The pain was reproduced and exacerbated by palpation of the posterior wall fibroid. The patient underwent a hysterectomy, and all of her symptoms resolved. This case highlights the importance of thorough assessment, recognizing the potential for visceral referred pain to mimic musculoskeletal conditions. Trauma. Now, let's talk about trauma. Any patient presenting with low back pain after trauma should be imaged to rule out a fracture. Imaging is essential for identifying pathology and contraindications to manipulation. We need to protect our patients by ensuring we're aware of any underlying conditions that could be exacerbated by treatment. The vomit phenomenon. While imaging is crucial, we need to avoid overusing it. Studies have shown that excessive diagnostic testing can lead to a worse prognosis, as patients tend to catastrophize and develop an external locus of control. The balance of imaging. We need to find the balance between protecting our patients and avoiding unnecessary testing. Imaging should be used to rule out pathology and contraindications, but we should not dwell on findings if there are no red flags. Conclusion. In conclusion, understanding the potential dangers associated with low back pain is crucial for our practice. We need to remain vigilant, recognizing red flags, performing thorough examinations, and utilizing imaging appropriately. Remember, our primary goal is to provide safe and effective care to our patients. By understanding the potential pitfalls and taking appropriate precautions, we can ensure that our patients receive the best possible care.